upon Dr. Kurian Joseph. He's a man who needs no introduction, and endoscopy man, and he has held many posts at international and national levels, and is presently Director, Joseph Nursing Home from 1980 to present, and working as endoscopic surgeon at Vijaya Hospital, Chennai, has received many awards and delivered orations and delivered lectures at national and international levels.
Good morning. At first, my grateful thanks to Krishna IVF and Dr. Ramaraju and Professor Ramkrishna Maraju Garu, who's sitting here. I'm coming back to Vizag after 10 years, and the changes I've seen in Vizag are absolutely super. First, the airport I went from was a small little shed. Now we have a huge big building. The hospital I went to, Krishna IVF, was a small room. Now they do everything from PGD to fish and all that. I still remember many years back, Dr. Ramaraju, when he came to my hospital soon after finishing his PG, he was so scared and quite worried what I'm going to shout at him and things like that. Now I've reached the level where I am scared to see him because he keeps asking me questions for which I don't know the answer. So I'm very happy to be back here. I bring you greetings from Joseph Nursing Home, and I'm very happy that the Krishna IVF has associated with us, and we have a very good IVF program thanks to his help and support. I also bring you greetings from the Asia-Oceania Federation of Obstetrics and Gynecology. This is an organization where we have got now 26 countries. We have added Macau, China, and Cambodia. And we had our last meeting at Taipei. And if you see one gentleman sitting and sleeping here, that is me. And I have incidentally just become the president-elect of this organization. We have just had, thank you very much. We've just had 2 people from India over the past 60 years. So my topic today is reproductive outcome in Müllerian anomalies. My work has become very simple because all the dirty parts of it, Dr. Ramaraju has already covered. So I can show you all the attractive parts of it. So in today's talk, I would just briefly like to highlight the problem of Müllerian anomalies, discuss the options in its management. Years before, this was what we were doing when we had Müllerian anomalies. You would depend on your vaginal examination, then you will get your professor to do a vaginal examination, and both couldn't do anything because that's all we would figure out. So today things have changed because we have multiple imaging modalities. We are able to see the pictures, and if needed, we can even operate and come to good diagnosis. But sadly, the prevalence or the incidence of congenital uterine anomalies has been very difficult to interpret. And the reason why it's become so difficult to interpret is each worker uses their own methodology. Some use different diagnostic methods, others use different criteria. Like you would have seen something which Ramaraju said is arcuate, I may say septate. Something which he says biconvate, again we are going to have confusion. So these varying etiology used has caused a lot of confusion. So this inconsistent interpretation of the classification has caused problems. If you see incidence-wise, around 6.7% is the reported incidence. But the incidence straight away doubles in the recurrent miscarriage group. If you see the factors, it may be polygenetic, may be familial, and a very, very small group is drugs and radiation. Although we always sit and talk DES, it's a very, very small part of the whole thing. Another very interesting observation is the incidence of arcuate to septate to biconvate. For every 12 arcuate uterus, you have around 5 septate and 1 biconvate uterus. So that is just the incidence of what happens. The cause of the defect he has shown you clearly, but it's just basically a fusion problem of the Müllerian ducts. Now, three aspects which again he had mentioned is first the organogenesis, that is the organ being formed. Second is the fusion of both. And third is the resorption of the septum after fusion. So if you have any error in these three, organogenesis, fusion, and reabsorption, we are going to get an abnormal Müllerian tract. So once you know this, and you know that it happens between 8 to 16 weeks of fetal life, we know now what the problem can be. The aspect which again he mentioned to us is that, remember that the Müllerian and the Wolffian ducts are very closely related. And most often if you have one anomaly, you may have another anomaly. So you have to always think, when you see a Müllerian anomaly, think of an ipsilateral renal problem. And renal agenesis may occur in around 40% of uterine anomalies. A very important point to remember. Also in the XY female, you think of severe uterine hypoplasia. So these are just aspects to remind you of what you have to look for. Now, how do you diagnose them? Most are asymptomatic till puberty. At puberty, some will present as outflow tract obstruction. They may come as hypomenorrhea, amenorrhea, and some would just come as severe dysmenorrhea when they have an obstruction. Some will come to you only when they get married and try to conceive and you find that they don't conceive. Some will present to you as obstetric dilemmas. When you have a malpresentation, then you palpate and you see a big biconjugate uterus. Some will come as retained placenta when you find the placenta stuck to a septum. Some uterine anomalies you may not find at all. And later on, when you're doing a hysterectomy for some condition, you may find a big uterine didelphys. So these are all the ways you will find the anomaly presenting to you, so be prepared for it. The diagnostic techniques, the hysteroscopy was rated as the gold standard. The sonosalpingogram and the HSG were techniques which we used. The sensitivity was just around 75%, but this was a very good screening tool. So if you don't have access to maybe 4D ultrasound, you could manage with one of these methods to give you a good guideline. The 3D ultrasound he has shown you very clearly. You can get lovely pictures, and very often when we have a doubt about a septum, whether to do hysteroscopy or laparoscopy also, we usually end up just doing a 3D ultrasound. A transvaginal ultrasound with saline again can show you a septum to very good effect. The MRI, however, is of limited use, but in a case where you have a doubt of pathology, it's good to do MRI because it would help you, especially when you're doing surgery. I'll show you some situations what happens. So if you a review of the different diagnostic techniques tells us that the most accurate is a combined hysteroscopy and laparoscopy, or you can do a sonohysterography or a 3D ultrasound. Less accurate is the 2D ultrasound and the hysterosalpingogram. And the MRI, as I told you, can be a little confusion. Now, the management, the biggest worry is the mere presence of an anomaly does not warrant treatment. So you get a young girl who comes to you with a small little septum. She says, I've been married for just 1 year. Please give her a chance to conceive and deliver normally.